Hello and welcome to the Super High Yield Anesthesia Podcast, the second edition. This is your host, Scott, the anesthesia resident. All right, thanks for tuning in to episode 16 of the Super High Yield Anesthesia Podcast. And today we'll be talking about anesthesia considerations for C-sections, emergent OB hysterectomies, and repair of a uterine rupture. As with previous anesthesia consideration episodes for specific procedures, my main source for this one is going to be Jaffe's Anesthesiologist Manual for Surgical Procedures, particularly the 5th edition. All right, like the previous episodes of this, we're going to briefly talk about the surgical considerations, and then we're going to move on to anesthesia considerations, the pre-op stuff, to intra-op, and lastly, post-op. Okay, so with all that said, let's go ahead and get started. So first of all, surgical considerations for C-sections, essentially if there's like a failure to progress in labor, or for example, if there's fetal distress or malpresentation, so things like a breech delivery that basically cannot do vaginal delivery, then that's when you can do a C-section. Or if the patient had a C-section previously, you're going to have an elective repeat C-section. Okay, and indications for emergent OB hysterectomy, things like profuse bleeding that is not controlled, and obviously things like for indications for repair of uterine rupture is rupturing is bad, so you have to repair it, right? So those are the main indications for this particular surgery. The position that the patient will be in is usually it's going to be supine, and you can have them on a little bit left lateral tilt to avoiding aortal caval compression. The incisions for C-sections generally, most commonly, is the low transverse incision, which is basically like below it's like a horizontal incision, like below the belly button. But the classical C-section is pretty much a vertical incision down the middle. Okay, so generally some unique considerations for these procedures is if the patient has fetal distress, they're going to have continuous monitoring of the fetal heart rate, heart tones until skin incision. Regarding antibiotics for these cases, generally speaking, you can use cefazolin or Ancef 2 grams. If the patient has a premature rupture of membranes, you can be adding azithromycin on top of the Ancef. General surgical time for C-sections is between 20 to 90 minutes. EBL for these cases actually could be very high. So 750 to 2000 cc's for C-sections, though patients could tolerate about like 1 liter of blood loss usually. So that's if you have upwards to like 900 cc's to 1 liters of blood loss, then it's not that bad. It's okay. But obviously, patient to patient, it's going to be different. So that's the surgical considerations, like the main ones that we have to be worried about. Next, let's talk about the anesthesia stuff. So first of all, we're going to do pre-op kind of system-based considerations. So first is the respiratory system, and regarding pregnancy changes, in the respiratory system, you have increased minute ventilation. So it's going to be kind of normal for these patients to have a component of respiratory alkalosis. So a PCO2 is going to be between 32 to 34-ish. And lastly, you can have a decreased FRC and increased oxygen consumption. And this is kind of scary for us because if they start decompensating, they're going to decompensate very fast because they have like zero reserve. Not zero, but very low. Okay. Next is the thing that I'm always scared about is the pregnant airway. For pregnant patients, the airway is going to be smaller and a lot more edematous. So it's going to be more difficult to intubate a patient that's pregnant versus a non-pregnant one. And generally speaking, you're going to be using a smaller ET tube size than you normally would. Our default in my institution is going to be a 6.5 tube, just in case the airway is very edematous and we can't pass a bigger tube through. And because of this, you can be careful when you're trying to suction the patient because you don't want to make the edema worse. Okay, so that's respiratory. Next is cardiovascular. And for these patients, it's normal for pregnant patients to have increased plasma volume as well as increased cardiac output. And the high yield point to know is that cardiac output is the greatest immediately postpartum in the entire pregnancy. So of all 3 trimesters, the greatest cardiac output is going to be right after they deliver. And the reason for this is basically once baby's out, the placenta, the blood that was in the placenta is about 600 to 800 cc's. And that's going to enter the central circulation, and it's going to pretty much increase the preload and increase the cardiac output that way. So that's something to be aware of. And another thing for cardiovascular is pregnant patients tend to have a decreased SVR, decreased diastolic pressures, as well as MAP, especially if they have aortal cable compression, which can be alleviated with left lateral tilt. Okay, next system is the hematologic system. Thing to know about this is there's an increased red cell mass, as well as increased plasma volume and blood volume. So something to know, there's different situations in which there can be increased blood loss. So things like uterine atony, multiple gestation, previous C-section, placenta previa, placental abruption, and prolonged labor. Okay, that's hematologic. Next is GI system. Thing to know that there's going to be increased intragastric pressure in these pregnant patients, mainly because the baby is kind of pushing up on the stomach. So then it's going to try to push the stomach contents upwards. You're also going to have a decreased esophageal sphincter tone due to progesterone. It kind of affects the lower esophageal sphincter especially. And one thing to note is during labor, like not before, these pregnant patients will have decreased gastric motility as well. So all of these factors put together makes you very, 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 very concerned for aspiration risk. So basically, if you're going to intubate a patient that's pregnant, you're going to treat them as if it's a full stomach. And before that, you're going to give a non-particulate antacid, so sodium citrate, or the brand name is Bicitra. In addition to that, you're going to give famotidine, brand name is Pepcid, and as well as some metoclopramide, brand name is Reglan, to kind of help with gastric motility. Next system, hepatic. Generally speaking, you're going to have a mild elevation LFTs and alk phos. And generally, it's from the placenta. But if you have like a lot severe elevation, then that's when you can be concerned for possible preeclampsia with severe features. But that's a topic for another time. And lastly, there's going to be a decreased plasma concentration, which is going to increase the unbound drug levels. Next, renal. And basically, there's going to be increased renal blood flow, as well as GFR, as well as creatinine clearance. And it's normal to see a decreased serum creatinine, as well as a BUN. Labs you want to get preoperatively. You definitely want to get a type and screen at the very least. And it's always a good idea to prepare the blood products, have it available in case you need it for these procedures. Because again, C-sections, they bleed or could bleed quite a bit. And having things like coagulation studies and platelet counts is going to be excellent for us, not only in terms of managing a hemorrhage, but also knowing whether or not we can do neuraxial techniques. Regarding pre-medication, you technically could give some midazolam or Versed if their patient is extremely anxious, but generally you can try to avoid that if you can. And again, we kind of talked about the medications for aspiration, so the sodium citrate, Reglan, metoclopramide, as well as famotidine or Pepcid. So here's the fun part. This is the intraoperative considerations for C-sections and the emergency hysterectomies and the repair of uterine rupture. So for these patients, because of all the issues that's associated with pregnant patients' airway, we're going to try to do neuraxial if possible. Because again, airway could be difficult. You have increased risk for aspiration. So neuraxial is going to be our best friend for these procedures. So again, advantages of using neuraxial techniques is there's actually decreased maternal mortality rate. There's a decreased risk for aspiration. The mother is able to participate in childbirth. And essentially, if you use a spinal, it's going to help with pain control as well. So if you listen to my previous episode 15, regarding the different analgesic techniques, you kind of are familiar with the different types already. So epidural, spinal, and combined spinal epidurals, the CSCs. Kind of fly through this a little bit. So epidurals, basically, when you're going to, if you want to use an epidural for the patient, for example, when they first come in, they need some labor analgesia, and then basically the steps for this, you can have monitors in place, you have post-ox, blood pressure cycling frequently, you're going to position the patient, usually they're going to be sitting for this procedure, you locate the space, usually using the iliac crest, you find L4, and you go right above that, so you're between the L3 and L4 space, and you're going to use the TUI needle, 17 to 18 gauge, with using the loss of resistance technique, whether it is saline, air, or a combination of both. And once you get it to the right spot, you can do the test dose or whatever your institution wants you to do, and look for any intravascular or intrathecal signs. So intravascular signs are things like tachycardia, palpitations, dizziness, tinnitus, or tinnitus. Intrathecal signs are things like motor block and super rapid onset of pain relief. Now, here's the interesting thing. If the patient already has the epidural and then you have to come back for an emergent C-section, you could convert the epidural for the C-section. And what you want to do is basically use preservative-free lidocaine. Usually you can use lidocaine 2%, and then you add a little bit of bicarb to it. And by increasing the alkalinity of the local anesthetic, you're going to have a faster rate of action, faster onset of action. So at my institution, what we usually do is 18 cc's of 2% lidocaine, preservative-free, plus 2 cc's of bicarb. So you have a 20 cc stick, and you just bolus 5 cc's at a time, or less if the patient is very short and small. And then you're going to be constantly checking the levels, just making sure it doesn't pass T4, because you don't want a high spinal. And then in addition to using this lidocaine solution, you could actually push either fentanyl or some morphine through the epidural as well. And if that doesn't work, you can even use some nitrous oxide, like 50% nitrous with oxygen, or you can even use IV ketamine to kind of help with the pain. But if none of those things work, then the last resort can be converting to general anesthesia. Okay. And again, like we discussed earlier, you're going to have left uterine displacement to kind of avoid the aortic caval compression. And right after delivery, you're going to have the rapid infusion of oxytocin, generally 10 to 20 units per hour. Okay, so that's if you had the epidural in place. But most times, especially if it's like an ambulatory C-section or like a scheduled C-section, you have time to do a spinal, and it provides a pretty good pain relief for after the procedure. The major contraindications of using a spinal is 1, patient refusal, 2 is coagulopathy, 3 is active neurological disease, 4 is elevated ICP, 5 is hypovolemia, and 6 is infection at the site of insertion. The pros of using a spinal is basically it's a lower risk for headaches. So it's as low as a 0.5 to 2%, especially if you're using the pencil point needles. So things like the Whitaker needles or the Sprotty needles. Some find it easier to place than the epidural. It has a rapid onset that's good for doing C-sections. And lastly, it's a pretty reliable anesthetic technique. Cons of using a spinal is the possible sympathectomy, having a decreased blood pressure. So one thing you can do to kind of mitigate this drop in blood pressure is having a fluid bolus. So you can either do a preload, which means that you're giving the fluids before you do the procedure, do the spinal, or you give the fluids as you're doing it, so co-loading. So essentially at this point, there's really no difference between co-loading and preloading. So it's kind of just whatever preference you want to do. Okay, and lastly, one thing you're going to be using after you're placing the spinal is vasopressors, especially phenylephrine. Historically, the vasopressor of choice was actually ephedrine because they thought that is improved circulation for both mom and the fetus. But recently, pressor of choice is actually going to be phenylephrine. And this is the pressor of choice because it has rapid onset. It effectively treats any decrease in SVR. It has limited placental transfer. And one thing that's a downside for ephedrine is that it could actually increase fetal acidosis. And the thought behind this is basically when you have ephedrine, it's, as you know, it's an indirect sympathomimetic, right? So that it releases a bunch of catecholamines. The fetus metabolism is going to be increased. And by having more increase in metabolic rate, you're going to make more waste products, and that's going to cause the acidosis. So that's why, so at least that's one reason why phenylephrine is the vasopressor of choice for pregnant patients nowadays. And if you're interested, I found this review article that kind of details this, and I'll leave the link in the show notes. Okay. And lastly, if the phenylephrine doesn't work, you can consider using other vasopressors, things like Levophed or norepinephrine, or even epinephrine. Okay. Steps for doing the spinal, basically the same thing, similar as doing an epidural. So having the monitors on, you have the fluids on, you have the antiemetics prior to the block, and you're doing the spinal with the pencil point needle. And the main difference is you're going to use an introducer needle for the spinal, and you're going to be puncturing the dura. And the recipe generally for spinals is you're going to use bupivacaine, 0.75%. The dose is usually 11.25 to 12 milligrams, which is kind of translates to 1.5 to 1.6 cc's. You can use Duramorphivit, like 0.1 to 0.2 milligrams. Fentanyl, 10 to 20 micrograms, or you can substitute fentanyl with Precedex, usually 4 micrograms. Okay, and the high yield board thing to know about this is you want to have the block going up to T4. So you're after the spinal, you started your vasopressors, patient's lying down, put on monitors, and you do the testing, and your goal is going to be T4. Not any higher though. Higher is bad. Okay. Lastly, for neuraxial techniques is CSE. As we kind of talked about in a previous episode, it's the best of both worlds, and the steps to do it is pretty much the same thing as the epidural and spinal. Okay, so there are times where you cannot use neuraxial techniques, and you're going to have to do general anesthesia. So indications for this, things like if there's some sort of hard contraindication to regional, there's not a time to do a block, there's like severe maternal hemorrhage, there's a prolapsed umbilical cord or severe fetal bradycardia, severe persistent fetal deceleration, or the need for uterine manipulation. So basically, GA is used when excrement is really hitting the fan, and you have to do the surgery like very quickly. So regarding induction, first thing you want to do is elevate the right hip, so basically the left uterine displacement to avoid aortic cable compression. You can pre-oxygenate as well as you can, and you're going to do rapid sequence intubation with cricoid pressure. Generally, we use propofol 2 to 3 mg per kilo with succinylcholine 1 to 1.5 milligrams per kilo, but depending on the patient, you can use other induction agents like ketamine or etomidate. So as we kind of discussed, like pregnant patients are potentially disastrous airways. So you have to know what you're going to do if you fail to intubate. So generally, we don't even mess around with DL. We kind of just go straight to GlideScope. But if that doesn't work, as long as you're able to mask ventilate the patient, just keep doing that while you figure out another method. Definitely avoid numerous attempts at intubation because the airway is already edematous, and if you continuously manipulate it, it's going to get worse. Definitely call for help. And if you're not able to mask ventilate the patient, shove in an LMA, and hopefully that works and continue the procedure. Or if you have the LMA that's compatible to pass an ET tube, definitely try that. But lastly, if the LMA does not work, you're going to try transtracheal ventilation or an emergency cric. So that's induction. Next is maintenance. You could use nitrous 50% with a volatile anesthetic. Generally, you want to try to keep the MAC less than 1.5, mainly to prevent uterine atony. You can actually use propofol drip to kind of negate the uterine relaxation effect of the gas. But you have to be careful that when you're using it because it could cause neonatal depression. Okay, other things to consider for maintenance is to avoid hypocapnia because this will decrease the umbilical blood flow. And then after delivery, a non-depolarizing muscle relaxant is rarely needed. But if you do need it, you can use rocuronium. Generally, you can reverse it whatever you want. So neo plus glyco, or you can use Gamedex. But if you do use Gamedex, mention to mom that there's effects on birth control, as in it would make the birth control less effective. All right. And lastly, regarding pain, you can consider doing a tap block or some sort of opioid. Regarding emergence, you definitely want to have an awake into extubation, just making sure that they're able to protect their airway. Because again, pregnant airways are going to be very difficult. Regarding blood and fluids, as we kind of mentioned earlier, this could be moderate blood loss. So you can expect to lose up to 700 to 1,000 cc's in a given case, and that's normal. Ideally, you can have 2 working IVs, and ideally, you can have at least an 18 gauge. Regarding monitoring, if it's a normal patient, you're going to have standard monitoring with fetal heart rate. But if the patient's critical, then having an A-line is great to closely monitor the blood pressure, especially if the patient's pre-eclamptic, and having a central venous pressure monitoring would be beneficial for other indications like pulmonary hypertension. Okay. Next, last things, positioning. Again, left uterine displacement to avoid aortic cable compression. And lastly, complications. Although relatively rare, one of the things you look out for or be aware of is the amniotic fluid embolism. The interesting thing about this is it's not an actual physical embolus. It's basically more of like an anaphylaxis reaction from the contact of amniotic fluid to maternal circulation. And the way it presents is generally hemodynamic instability, hypoxemia, and DIC. And treatment for this, unfortunately, there's no like silver bullet. It's just going to be support. Okay. Lastly, postoperative complication or postoperative concerns regarding complications. A venous thrombosis is possible for these procedures, but the thing that you're kind of worried about the most is postpartum hemorrhage. So again, it's very important to have the patient type and screen and have blood available for every C-section you go to. And we'll kind of talk about postpartum hemorrhage in the next episode or in a future episode. Okay, guys, that is it for this episode. Thank you very much for sticking in with me. As I mentioned in the previous episode, we have a lot of OB episodes coming up. So I hope you kind of stick around to listen some more. And if you haven't done so already, I would appreciate if you take the pre and or post surveys for this episode, just so I know if you're learning anything and if there's any suggestions that you have in improving this show. Okay, for the fun fact I have for you today is from Bino.com, and it's basically the dot over a lowercase I and J actually has a name to it. Apparently, it's called a tittle, which is a noun meaning a tiny amount or part of something. So yes, very fun fact. All right, thank you so much again for tuning in. This is Scott, the anesthesia resident, and I look forward to seeing you in the next episode.